The following educational video was created in collaboration with the Faculty of Biomedical Engineering. Intraosseous access. Intraosseous access is an alternative method for securing access to the vascular system, allowing the administration of medications through the vascular system in the bone marrow. Unlike venous access, the bone marrow network does not tend to collapse. Due to its rapid and relatively simple placement, it is most commonly used in pre-hospital emergency care or in military medicine. Indications. Intraosseous access is introduced in all life-threatening conditions when it is necessary to quickly provide medications and no alternative vascular access methods are available. The access remains in place for a maximum of 24 hours. There are several methods for securing intraosseous access. In this episode, we will discuss how to secure access using a semi-automatic tool, namely the SIO drill. For securing intraosseous access, we will require the following equipment: infusion fluid and set, a pressure cuff for infusion therapy, a 20 milliliter syringe with a luer lock, pre-filled with flushing solution, skin disinfectant, and non-sterile gloves. Included in the SIO set are a semi-automatic drill, introducer needles, and stabilizing adhesive patches for use during procedures, a connecting tube, and a safety container for used introducer needles. There are 3 sizes of needles, each color-coded. The yellow needle is used for obese adults, patients with significant musculature, and for drilling into the proximal humerus. The blue needle is intended for regular adult patients and for placement into the tuberosity of the tibia. The red one is for pediatric patients. The needle has a special shape for better penetration of the bone. Insertion of the intraosseous line into the tibia. The actual procedure demands adherence to the strictest sterile conditions. Before the procedure, it is necessary to prepare all tools, select an appropriate needle size for the specific patient, and attach the needle to the drill. Select and palpate the ideal site for insertion. When applying to the tibia, the site is about 2 centimeters medial to the tibial tuberosity. After mechanically cleaning and disinfecting the puncture site, the skin must first be punctured down to the bone, where resistance can be felt. Once the needle is in place, pressing a button activates the drill, and with gentle pressure, it is pushed into the bone. Drilling must be stopped upon loss of resistance. The needle must be inserted so that at least one marking is visible. The drill is removed, then the introducer stylet is taken out of the needle and disposed of in a sharps container. The needle is secured using a special fixation adhesive, and the pre-flushed connecting tube is attached to it. Bone marrow aspiration is performed, followed by a thorough flush of at least 10 milliliters. For kids, use 2 to 5 milliliters to break through the bone trabeculae and allow the passage of administered medicinal products. The actual insertion of the needle into the bone is not significantly painful. However, the subsequent flushing is significantly painful. Therefore, in conscious patients, it is advisable to first slowly instill a local anesthetic, for example, 5 to 10 milliliters of 1% mesocaine. Alternatively, in consultation with a physician, consider another suitable analgesic, for example, ketamine intranasally. Only then should the flushing and subsequent medication administration be carried out. The onset of action of medications via intraosseous access is comparable to central venous administration. The only difference is the increased pressure in the intraosseous space, which requires medications to be pushed into the circulation under higher pressure, for example, using a pressure infusion cuff for fluid therapy. All medications intended for intravenous administration can be given through intraosseous access without any difference in dosage. The intraosseous access site should be labeled with the date and time of insertion. It may remain in place for a maximum of 24 hours. Contraindications for intraosseous access include break time 1.0s, fracture of the target bone, infection at the insertion site, excessive soft tissue, severe obesity, or absence of adequate anatomical landmarks for identifying the correct insertion point. Previous intraosseous access attempts in the target bone within the last 48 hours, or major orthopedic surgeries, break time, presence of a limb or joint prosthesis at the target site, procedure for removal of intraosseous access. First, the extension tubing is removed. Then, the fixation patch is lifted and removed, and a luer lock syringe is attached to the end of the needle. Maintaining the correct alignment along the axis of the inserted needle, rotate the needle clockwise with the syringe while applying traction in the axis out of the bone. The needle must not be bent or tilted, as this may cause it to break. Once the needle is removed, it should be disposed of in a sharps container along with the syringe. The original intraosseous puncture site is then properly treated with local care. First, the arm must be stabilized to prevent unintended movement. In pronation with the palm down and elbow flexed to 90 degrees. The correct insertion site can be identified using two hands. One is placed with the ulnar edge at the junction of the deltoid and pectoral muscles, the other on the center of the deltoid where the shirt seam runs. Using both thumbs, move from the upper arm to the shoulder until the edge of the humeral head is found. The insertion site is about 2 centimeters cranial toward the head from this edge. The needle angle should be 45 degrees, directed toward the opposite hip. Summary: intraosseous access is used in life-threatening situations where alternative access cannot be obtained. After disinfecting the site, pierce the skin with the selected needle on the drill without activating it until bone contact is made. Activate the drill until resistance is lost. Remove the stylet and place it into the sharps container. A depth marking should be visible on the inserted needle. Fixation is performed using a special adhesive patch. The pre-flushed extension tubing is connected to the inserted needle. The first application is significantly painful. Analgesia must be considered. Medications are administered using a pressure cuff. The access should be removed no later than after 24 hours.